the question of really ageism in PSA screening. So screening, and I think I can talk about that because I'm actually have got 2 grandchildren, so I'm old enough now to start thinking about what happens when I need to retire. Right, so screening for prostate cancer, as you know, is a contentious subject, and screening for men over the age of 70 is even more so. And part of that is to ask ourselves, what are we looking for when we screen for prostate cancer in the over 70s particularly, and what are we going to treat and why? So it's not really a question of, do I want to find all cancers or any cancers, but the ones that are important. And we're always, when we discuss screening for prostate cancer, it's always a question of benefit versus harm. So I came across this. So PSA screening in New Zealand this is our guidelines here, which I completely disagree with. But anyway, in New Zealand we have this very unique suggestion, which is that if you're under 70, you use 4 as the value, and once you're over 70, it magically turns into 10. There is no literature evidence for either value, and there's particularly no evidence for the last statement. So PSA, of course, is lots of different things. It's a test that men here use. It's a bad problem for people who grow kiwi fruit, but it's also the name of a union in the hospitals. But I think PSA should be the same value at any age, rather than being differentiated. So here are the guidelines, the international guidelines. So we have the AUA guideline, which is that we don't recommend screening for men over the age of 70 or with a life expectancy of 10 or 15. And the American Cancer Society guidelines are 10 years. And these are all actually based on a PSA of 4. If we look at screening, if we're going to talk about screening for men, we have to go back to the only paper that bears any scientific validity, and that was, I think, with the European Randomised Screening Program. Men in that were up to the age of 74, so they included people who were over 70 to screen. The cut point was 3, so if you had a value over 3, you had a biopsy. And they screened every 4 years or sometimes every 2. In New Zealand, we often screen every year, and that's a sort of a New Zealand-Australia thing. And there was a significant evidence of a reduction in mortality. The French data got thrown out because they didn't behave and wouldn't do the protocol. So they did their own thing. And the Dutch and the Germans didn't like that, so they've thrown them out of the study. But this is the survival curve for prostate cancer. So you can see that if you screen for prostate cancer in the group, 50 to 74-year-old, you will reduce the risk of dying. And that's about a 30% reduction at 13 years, but it's only for cancer-specific mortality. And the reason it remains controversial is it's not overall survival. So, screening reduces the risk of dying from prostate cancer, but as we've said, screening is controversial. And you do need to screen a lot of people to save a few lives, and there are side effects. So a lot of the conversation that's happened today have been about those side effects: continence, erectile dysfunction, recurrence, and uncertainty. Now, in Hamilton, we use age-adjusted PSA, so that's been our style. We've decided that 3 or 4, whatever value you want to use, is maybe a little bit low for men in their 70s because they will have a slightly higher PSA on average because their prostates are larger. So we've used age-adjusted PSA, but there's no good studies to back that, and it maybe is too complex. But here are the papers that talk about age-specific, and we've used Ersteling, so we use 2.5, 3.5, 4.5 and 6.5. So if you're a younger male, we'll use a lower PSA at which you should be screened, and if you're an older male, then we'll use 6.5, but certainly not the 10. And so this presentation grew out of a review of our biopsy results at Waikato Hospital. So we went back and said, well, look, we don't follow national guidelines. We've been arguing with the guideline panel about it without making any headway, and we decided to review our results. So in our public, and not all of these are men who are over 70. So some of these are men who are younger than 70 who we did their biopsy at lower PSAs and national guidelines. So within our group in public, we had 363 patients, and just about 1 in 5 we biopsied outside the New Zealand guidelines. And of those patients, you can see that quite a lot of them actually had a reasonable cancer. So 44% had a Gleason score 7 or higher, and yet we had biopsied them at PSAs that the national guidelines didn't suggest. One patient had already had metastatic disease. His PSA, I think, was 5. And in private, it's a similar number, although, again, you can see that the patients we biopsied slightly more outside the guidelines, and that's probably slightly more older patients, and again, significant cancers. So if we just look at those men who are over 75, or over 70, and particularly in that 70 to 75-year age group, because they're the men who are still fit, healthy and well, but sort of regarded as over the hill by the guidelines. And within the public system, we had those patients there. So we can see that in the 70 to 75-year-old age group, the men we went and biopsied, so we biopsied 71 men, and 32 of those had a PSA less than 10. And even in the 80-year-old age group, we were biopsying quite a few men who had PSAs less than 10. So of those men, you can see 22 out of 32 actually had cancer, and 11 of the 22, so 50%, were a significant cancer. And in private, slightly more men outside the guidelines. And I said that's my clinical practice. I see these patients in private. And to be honest, in private, you tend to see slightly more healthier patients. And that's to do with a life of, so the word I'm going to use, affluence, is not right, but it's the opposite of poverty. But there's a concept that a life of having to strive actually impacts very badly on your health. So anyway, in the private sector, we had six out of 9, so 2/3 of the men I biopsied were outside guidelines, and 5 had cancer, and 4 of those 5 were significant. Put them together, similar numbers. So we're looking at about 30% of the patients having a positive biopsy, and about half the patients we biopsy are under New Zealand guidelines. And we can look at that as a scatter plot. So here's all the men who are 70 to 75, and this is their PSAs under 10, because 10's the cutoff in New Zealand. So these are all men between 70 and 75 who had a PSA of less than 10, who went forward for a biopsy, and the negative biopsies and the positive biopsies are there. So you can see that they're very scattered, they overflow, and there's no way you can tell who was or wasn't positive. So there are quite a lot of men who are just above that red line who have the yellow dots are all the people who had prostate cancer. So 70 to 75-year-old males with prostate cancer between the New Zealand guidelines and what we think is reasonable. Putting that in numbers, almost 50% of patients we biopsied are over between 70 and 75 were under the 10 threshold. Quite a lot of those were positive, and a reasonable number of those had significant cancer. So it's not that we're over-detecting trivial, low-grade, small-volume cancer. And when we go back to those guidelines, the interesting thing is they all include life expectancy. So they seem to make an association that at 70 your life expectancy is 10, or maybe if you're super lucky, 15. Similar there. So, and I would put it to you that most 70-year-olds these days would expect to live beyond 10 years. And if you went to a funeral of a friend and he was 72, you'd think he died young. So Professor Sarah Harper was interviewed last year on national radio, and she had some lovely things to say. But one of the critical issues in dealing with who we screen and who we shouldn't screen is to do with how hard your life's been. So if you've grown up in a deprived area and you've worked hard and you've done physical labour, you will die young, and you'll die young being in your mid-70s on average, and you will tend to die in poor health. And if you've grown up in an affluent area of England, this is United Kingdom, you will live into your 80s, and probably your late 80s, and you'll enjoy good health most of your life. So it's not that you're old and infirm, you'll be old and well. So we need to rethink where old age starts, and in fact we need to remember that half of men die over 80. So, what do we think the life expectancy of a male in New Zealand is? So what's the average age at death in New Zealand, a New Zealand male? Any thoughts? 74? 84 and 76. All right. So 80. Not bad. So it's higher than we think. And if you were 60, what do you think you're going to make on average? Yeah. There we go, 86. So if you make 60, you should make, on average, 86. All right? And if you make 70, you should have a little bit of survivor benefit. All right? So yes, so if you thought the heartbeat was going to pop off in 10 years, you've got another 20 to go. All right. But if you make it 70, you don't gain a lot more. So we're biologically fated at the moment to sort of not get past 90. So we get another 10 years, and the numbers, they get a little bit better, but not as much as you would want. All right. And so when do we think the 10-year mark is? So we had that protocol that said no screening after 70 or men that aren't going to live 10 years. What do we think 10 years is at? Yeah, it's about bang on, 79. All right. Now, if I advocated for a 78-year-old to be PSA screened, I'd probably get into big trouble. But the concept's there that we're not being fair to men as they age. And this is life expectancy in New Zealand over those years, and you can see that it's gradually getting better and better and better. And the interesting thing in this is, so I'm sub 60, but when I was born, I think my average life expectancy at my birth was 68. So I was born 65, so my average life expectancy now is 81. So in my lifetime, that's improved by 10, yeah, good 10 years of gain. And I think as doctors, we haven't made that connection and understood that well enough. All right. So when you were born, you know, for people in this room who were born when they were, maybe who are 75, when they were born, average life expectancy for a male might have been 62. They've already exceeded that, and they've got maybe to 88. So the crux of this is that well men in their early to mid-70s have at least 15 years of life left. Now that doesn't mean we should treat you. It doesn't mean we should even find out whether you've got cancer. So do we have any information on prostate cancer screening in these age groups? So this is a slightly complicated slide, but the blue line is the probability of you, so the age is on the bottom, so as you get older, the blue line is the probability of you having no treatment if you're found to have prostate cancer. And the red line is the probability of you receiving treatment. All right, so we can see from, there's another one coming up, show that we know as men age that they don't get treatment. Now underneath that are two other little lines, and the one that goes down very aggressively is the men getting radical prostatectomies. So we can see that as men age, the chance of having a radical prostatectomy plummets, whereas radiotherapy is the line that's just sort of chugging along at the 30% mark. All right. So we've got literature evidence of age bias in terms of treatment. Now, what should determine treatment? So treatment should be determined by your comorbidities. All right, so it's not how many years you've got under the belt, it's how many years we expect you to live. So this is comorbidity score along the bottom, and what have we got up the top? So probability of getting the treatment. So what should happen is that the probability of getting treatment, these are age bands going across, should be the same for your comorbidity index. So you should be treating people based on their comorbidity, not their age. And we can see that when you get old, it doesn't really matter whether you're extremely fit or not, or even not bad, you're not receiving treatment. And these younger men who are very ill are still getting treatment. And this is the same thing. So again, older men, this is radiotherapy, this is surgery. So very little surgery in older men, despite being very healthy, and younger men who are not well and never should go near the operating table are still getting operating. Similar concept, so this is whether they get intervened or not, and we can see as you age, it doesn't matter whether you're in good nick and expected to live a long time, you're not receiving this is surgery in black, so surgery suddenly disappears, and people who are pretty sick, because they're young, they're still getting surgery, which is inappropriate. Now there's some good news, perhaps in the literature, there's very little literature on this, but this is time frame, so we can see as time goes by, as people who are older and well, so this is another form of comorbidity index, so this is well people. And you can see when you're young, you're getting 80% intervention. Now some will be active surveillance. But when you're old, it doesn't matter that you're well, you're not getting treatment. But the good news is that that's changing. So this is over year time. So clearly bias exists as to treatment choice. That bias is perhaps getting less with age. The next question is, does that affect outcome? Because at the end of the day, if bias exists but the outcomes are the same, does that matter? Now this is the classic Albertson graph, which shows survival for different cancers, and the important bit is in the blue. So this is older men with higher grade cancers. All right? And you can see for most of those groups, this is the chance of dying from your cancer, and that's the chance of dying of other disease. So I think this might be 80s, I can't read it from here, but you're going to die within 15 years, that's not a surprise. But still a lot of people are dying of their cancer. Now this graph has largely been used to imply you shouldn't treat people as they get old, because the probability of dying of your cancer decreases the older you are because competing causes starts to come in. But if we look at what happens to men with locally advanced cancer who are not given curative treatment, this is the probability of dying of your cancer for a Gleason 7. This is a chance of you dying from your Gleason 8 within 8 years of diagnosis if you're over 70. So if you're 71 and you have a Gleason 8, oh sorry, that's 75, Gleason 8, your probability of dying of your cancer is at least 40%. So withholding treatment has a bad outcome. So I think the Albertson charts have unfortunately been used with the best intentions. We try and prevent unnecessary treatment in people, but treatment matters at all ages. Now, if we know that treatment outcomes are worse if you don't treat patients, it stands to reason. What happens when we do treat older men? So this is radical prostatectomies in men over the age of 70 or 75, I'm not quite sure. I'm not sure if it's projecting well enough, but continence rates are slightly worse and erectile rates are terrible. And there's a slightly higher, I think, might be bladder neck contracture rate. Cure rate's the same. So if we do radical prostatectomies in older men, same rate chance of curing them, slightly higher incontinence rate, slightly higher and very high risk of erectile dysfunction. So my take is that well men in the early 70s have a life expectancy of 15. Age shouldn't deny you from treatment options and by inference screening. And your treatment should be based on the cancer, how aggressive it is, the patient, so their life expectancy, and but not their age. But there is a plea, which is if you are going to screen, you should screen correctly. So I believe this value of 10 is far too high, but part of the problem with screening is the concept that you have a blood test, the blood test leads to a biopsy, the biopsy leads to treatment. And that's incorrect. So a PSA is just one of a bunch of tests you should have before anybody goes near you with a needle. But the problem is we see PSA as automatically being an escalator. You get on the bottom and up you go on the escalator and away you go. And out the end you come out with a radical prostatectomy or radiotherapy without anybody necessarily thinking that through. And that's the problem. Whereas really, PSA should be like some steps. You have an opportunity to stop at the landing. Sometimes it goes wrong. You have a chance to recover. And you can start again if it doesn't go too well. So PSA should be the initial starting point on a pathway, but it's not a determination of you ending up being treated. And if we don't break that, then we can't screen older men. Okay, so a lot of repetition, but hopefully by that we win. So PSA should be much lower in men who are over 70. I think it should be maybe even 4. But you can only lower it if you're going to accept you're not going to biopsy everybody who comes to the door. We've shown in our group that using 6.5 detected men with significant cancers who would have been missed if we'd used New Zealand guidelines. And I've recommended that the guidelines are modified without any gains on that front. We need to separate PSA from immediate biopsy. I mean, that can be done a number of ways. So there are PSA calculators. Very few urologists use those. There's a thing called the SWAP calculator, which came out of the ERSPC, so you can go online, you can put in your data, tells you the likelihood of you having significant cancer, or tell you not to have a biopsy if your risk of cancer is less than 12%. And you should be adjusting the PSA for the prostate volume. Now that might require you to have an ultrasound. Everybody should have an MRI before anybody puts a needle in you. There's no other organ system in the world that somebody would throw a dart into your body based on a blood test. In the future, you'll have urine biomarkers. Caldara here doing research on that. There's a group in Boston. And so you'll have a liquid biopsy. And so what we'd like to do is biopsy men who have a reasonable chance of cancer, but not to deny them a biopsy simply because they're too old. We should also always increase the number of men going into active surveillance, so we accept that not all cancers need to be treated. You need to individualise your therapy. And although it's outside this discussion, we will be increasingly treating oligometastatic disease. So the way we treat cancer changes, and it's going to change, and it's going to change in the old people. And oligometastatic disease means 1 or 2 bone metastases. And so the PSMA PET becomes critical for that. Then you can see these funny lesions. And then now there's data out to show that if you treat patients with hormone therapy for their metastatic disease and they've got 3 or less metastases, if you then irradiate their prostate, they have increased survival. So we need to actually think through things a little bit better. All right. And as I said, I think we need to think smarter. So here's an MRI of a patient's prostate, and this had a negative, I think it had low-grade cancer on the initial biopsy. So he came to me, one of my specialist interests is MRI-guided prostate biopsies, and there's the cancer sitting there. So it's quite a decent cancer, but it's right at the tip of the prostate, and it's midline, so it's often missed during an ordinary prostate biopsy. You would have been able to see it if the urologist had taken the time to look for it, but we're not good. So urologists aren't trained in ultrasound, and I think we have a low skill score on the complexity of ultrasound. So there's the tumour there. Now, he was booked for a radical prostatectomy, but what's the problem? So the problem is a couple of things. One is, if it comes out, is that he's got a really big bone in the way. And that then means the angle coming in here is really, really tight. So the surgeon's going to have a really difficult time trying to get to the tip of that prostate. And if he doesn't get to the tip of the prostate correctly, one of 2 things will happen. He'll cut through the cancer, and you have a positive margin. You have to go and see the radiation oncologist and see Leanne, and Leanne will wonder why she didn't see you first. Or he'll cut through here, and then you'll be incontinent. And the really big problem for this patient is he has no sphincter. So on this MRI, you can see preoperatively, there's no gap here. So there's no membranous sphincter. So this patient, if he has a radical prostatectomy, will be almost guaranteed to be incontinent. So luckily for this patient, the surgeon bailed because he couldn't actually get in through here. But he almost certainly would have had a positive margin and incontinence post-surgery. All right. So I think we need to think a bit cleverer, select our patients. But as I said, it's not an escalator. He had a biopsy, doesn't mean he has to have surgery. All right. So I think you should screen for cancers in younger old men, and we should in a way it's specific to life left, not the years lived. And that's the end of the talk.